Well, let me begin by thanking my good friend, Dr. Richard Bowe, for joining me. Rich has worked as an anesthesiologist going on 32 years at Phoebe Putney Medical Group in Albany, Georgia. Until a couple of years ago, Rich also served as the chief medical officer for the group. He is a tireless worker and one of those people who will always be there to help another person. I really enjoy my relationship with Rich. We've always been good friends, and it's fun to get with him and do things. But I have to tell you, I'm so honored to have him as a true friend. So with that, hi, Rich, and thanks for joining me.
Hi, Tony. Thanks for having me. I appreciate the opportunity.
So first, foremost, how are things with you, Carol, and the kids right now?
Well, they're strange. I'm here in Albany by myself. The rest of my family is scattered around. I've intentionally left Carol and Hannah, who would normally be here in Albany, in South Carolina, away from here, so that I don't have to worry about bringing something home to them and making them sick.
Yeah, I'm hearing that way too often. It's got to make it even tougher going through this, I'm sure. But and are you going to be able to get to see her for her birthday?
No, I'm not gonna make it for her birthday, unfortunately. So we'll get together in a couple of weeks, I hope.
Yeah, well, we sent her a nice video, so hopefully she'll enjoy that.
Well, I'm sure she will, and I appreciate your doing that. Thank you very much.
Absolutely. Let me ask you in that vein, how are you personally feeling physically, emotionally, professionally? How is all this resonating with you at this point?
As far as physically, I'm fine. Our OR schedule is way down, but we find ourselves doing things out of our ordinary routine to take care of patients here. Emotionally, it's tough. It's a challenge to see these patients as sick as they are, to be out of your comfort zone professionally and what you're used to doing. And then being alone is also very difficult, coming home to an empty house at night and just trying to decompress all by myself without having anybody to talk with is a challenge.
I would imagine, I don't want to put words in your mouth, but I would imagine that the emotional part that comes with helping people has to be even difficult because it's so hard dealing with this. It's probably hard to find joy and even that you're doing something good for people.
Well, you don't see the returns right away. There is no instant gratification in this. You have to kind of take the long-term view and realize or hope that what you're doing is having an impact to what everybody's been calling flatten the curve.
So this has obviously been a crazy couple months. It doesn't seem that long ago since we were all together. But during this time, we see all the things on the national news and witness those that are hit hardest by COVID-19. The national news is really focused primarily on the major cities. That's what you hear about all the time, right? New York City and LA and New Orleans. However, Albany's actually been highlighted a few times in the national news. I know a few of your doctors and Scott Steiner have been on the TV a few times. So even though Albany is considered somewhat of a smaller city, it still has been extremely hard hit. And it seems like as a per capita level, it seems like it's inordinately been hard hit. So I thought it'd kind of be great to get your take on the effects it's having on your particular specialty in anesthesia and also the community as a whole when it's that much is hitting a community that size, which many people might even consider rural.
Well, you're exactly right. I mean, we have been up until recently, and I don't know where we stand right now, but up until recently, we've been the third highest per capita incidence and the fourth highest per capita death rate related to COVID. Our MSA is about 80,000 people, and we've got almost 1,700 positive patients in the MSA. We've had almost 60 deaths from COVID. So it really takes its toll. We were early adopters, which is not a good thing in this situation. But fortunately for us, our community leadership took heed of what was being put out by the federal government and their recommendations. And we've been in a shelter in place, sequestration, social distance situation for over 2 weeks now. And I think we're starting to see some of the benefit from that. But the community has really come together to support the healthcare community. As I alluded to earlier, everybody in the health system finds themselves in unique positions. Professionally, the anesthesiologists are helping to staff one of the new ICUs. We've created 2 new intensive care units to help handle the influx of the critically ill. And the anesthesiologists are helping to staff one of those, as well as the nurse anesthetists. We also have anesthetists that are covering respiratory therapy because we've had many respiratory therapists go out with COVID positive or not come to work. So professionally, we find ourselves challenged in ways that we aren't used to being challenged, which also adds to the emotional, psychological stress of what's going on. You get out of your comfort zone, and it takes a lot more effort to do the right thing for people. But overall, we've as a community come together. We've had great support from the community. We've had people in the community making mask covers to cover our N95 masks so that we can reuse those and just wash the covers. They're reusable covers. We've had restaurants in town and civic organizations in town bringing food to the hospital workers. It's despite all of that's gone on, that's the silver lining to this for our community anyway, is just the community support across the board and the support of the medical staff and all of the staff at Phoebe doing what we need to do, whatever that is, to take care of the patients here.
Let me ask you, with the expanded ICU units that you brought in, how many beds does that put you at roughly for the ICU?
We normally have about 38 ICU beds. We probably have close to 60 ICU beds now.
Close to capacity?
Yes, very much so. We've got, last count I heard at the beginning of the week, we had over 40 ventilated COVID patients.
Wow. Oh, that's crazy. So you kind of answered my next question about, as an anesthesiologist, anything elective has probably pretty much been put on hold, I'm assuming, until this is all over with. So it sounds like you guys are keeping yourself busy. What about some of the other surgeons and specialists? Are you seeing everybody kind of doing this, or are some of those people not really able to help out that much?
The vast majority are finding ways to help out. We've got cardiac surgeons, general surgeons, trauma surgeons who are also helping to staff the critical care units by doing procedures to unload the procedural side of it from the ICU doctors. We've had our primary care physicians. We did not have a telehealth program at the time this started, and Dr. Fricks, who's one of our primary care physicians, he got the telehealth program going within about 72 hours so that we can help take care of the patients that don't want to come or can't come to the office, that we don't want them to come to their offices but still need care. We've got orthopedic surgeons who are setting up a walk-in clinic outside of their office to help offload the strains and sprains from the emergency room. But you're right, I mean, early on in this, we kind of anticipated seeing what was going on other places. We kind of anticipated that we were going to be pressed for resources. And so we stopped elective cases early on in this process. We did urgent and emergent, and we're still at that point. I'm hopeful in the next 2 or 3 or 4 weeks we can kind of loosen the controls on that. I'm hoping that we're starting to see our curve here flatten. We're, as I said, early adopters. I mean, we're not very far behind New York City, and we're way ahead of Philadelphia and New Orleans and Denver and those kind of places. So I think that as COVID moves through the United States, there are going to be peaks at different times in different locations. But the more people can do to adhere to those federal recommendations as far as social distancing and isolating in place, hopefully the smaller the peak is in these subsequent locations.
So when you've put up the new ICU help units, so to speak, how have you done that? Have you had to use other parts of the hospital, a separate office building, or how have you guys found the space?
Well, the first ICU that they opened up that was not traditional or CON ICU space was in the recovery room, which is another reason that we stopped our elective procedures because we knew we were going to need that space. And we've been using old anesthesia machines or new anesthesia machines, both, as ventilators because we've run out of our stock of traditional ventilators that we use. So the patients that don't need complex ventilatory modes will get put on an anesthesia machine, and we'll use that as a ventilator for those patients. Then the second ICU they opened up was on one of the floors, and again, you try and equip that as best you can because it's not built to be an ICU, and so there are a lot of logistics that go into getting the equipment and the suction and the oxygen and all of that in those rooms that need to be, plus the staff that has to go up there and help cover that. We've had anesthetists sitting with patients that are on the floor, not even in one of the new ICUs that are on the floor that need a ventilator. There's no place for them in the intensive care unit, and they have to have one-on-one nursing because the floor nurses don't have the experience to cover that ventilator and all the drips that are involved.
Wow. Well, just unbelievable challenges. It's amazing. And now that this has got, I know it's been going on for a while as you've been trying to get these things up to speed. Do you feel like you're getting to the point where you have adequate staff and supplies and such?
Yes, we've never run out of anything, staff or supplies. The staff kind of waxes and wanes because we've had staff members, physicians, nurses, respiratory therapists, transport people all become COVID positive, and so that takes them out of the mix for 10 days or 2 weeks until they recover. But to this point, we've been fine with staff and equipment. Now, we're not flush with our equipment on a daily basis. You kind of have to go search for a mask, but they're there. You just have to know where to look to find them.
Okay. So it sounds like what you said earlier, the community and the local government and everybody is taking this seriously, and the social distancing, you're not finding people not adhering to that for the most part.
For the most part, no. I mean, there will always be some. Our index case, it appears that was a person who visited for a funeral here in town, and it was a large funeral, and so multiple people who attended that funeral were positive, and it was just exponential, the growth, because there was such proximity and a large group of people that were initiated by somebody who had the COVID virus unknowingly when they came down for the funeral.
Wow, it's amazing how quickly something can start.
That's the importance of social distancing, is you never know. I mean, there are people out there that are carriers that are COVID positive, that are symptom free, and you don't know who they are. And you may feel like, oh, I'm okay. I'm going to go be with my buddy, or I'm going to go have a couple beers or whatever it is, and just don't do it. I mean, it's just not worth it. Even if you are COVID positive and you're not sick, you don't know who you're going to make sick. Your buddy may not get sick, but his wife or his child or his mother may get sick. And that's the importance of the social distancing. And you can see how much that plays a role just by virtue of the fact of how many people who attended that funeral were people that turned out to be positive. And we don't know everybody who attended that funeral who is positive. We just know that there are a lot that showed up at the hospital that were.
Sure. So let me ask you, what have you and your staff really learned from some of the other areas that have had even greater number of cases and deaths and so forth? Have you learned much from that, or were you already on the right track before you hear all these things?
Well, this is new for everybody. And so our critical care doctors are excellent at looking at the literature, looking at what other places are doing, adopting the hydroxychloroquine and azithromycin, trying that out, whether or not this is an inflammatory process that needs to be treated with immunosuppressives. There are lots of things that are going on. We've been fortunate in that we have just recently extubated successfully our 7th or 8th ventilated COVID patient. And it took a long time before we had anybody who got extubated. But in the last week, we've extubated 7 or 8 patients successfully from the ventilator. Several have been discharged from the hospital already.
So that's a good sign. Maybe, my hopes are that it's starting to flatten at least a bit.
I hope so too. Every day the hospital's very good about being transparent with the numbers, and every day they put out a dashboard. And I look at that and think, all right, now how's this compared to yesterday? What's the death rate kind of lags behind the incidence, but one of the things we did have problems with was the availability of testing. We finally had gotten FDA approval to have our own testing here on site, and that just started this week. But we were looking at turnaround times of 10, 12, 14, 15, 16 days, and it's really hard to know who to isolate, who not to isolate, who to initiate treatment on when you don't even know if they're positive or not. So that's, I'm hoping, making a big difference to us in flattening the curve out, knowing who to treat and how aggressively to treat those patients.
Also, it seems to me that we hear so much in the news. I mean, our news, it seems like over the last several years, you don't know what's sensationalized, what's not, what's real. Have you heard things that seem more myths than fact, or do you think everything that's being reported is pretty accurate at this point?
Well, I think both sides of the aisle tend to politicize this for their benefit. We've just been so immersed in trying to dig ourselves out of this big hole. What I would say to people listening is, this is real. I mean, this is the real deal. It's a pandemic. People really get sick. People really die. And to not follow the recommendations of the federal recommendations, you're just asking to be in the same situation we are. I mean, as I said, we were early adopters here. We were in the middle of it before anybody really knew what was going on anywhere. Our index case was in February. And so by March, by early to mid-March, when the federal guidelines came out or federal recommendations came out, we were 2 weeks into this thing already. And so we've just been keeping our heads down, trying to do the right thing, and taking as much information as we can from other places that have experience to help our community here.
What do you think has made this one so much more intense and gotten us to this point as some of the other major viruses that have hit us in the last 10, 15 years?
I think this one is much more communicable than the others. The fact that there's no vaccine means that everybody is eligible to be infected. It's not like the influenza virus where there's a vaccine and the majority of people get the vaccine. Even if they don't guess the strain right, there's still some immunity commuted by the vaccine. This is a brand new virus. It's very, very communicable and transmissible, and patients get sick. One of the things we've seen which really leaves an impression on you is the patients don't look sick until all of a sudden, once they start to go downhill, they go downhill very, very quickly. And so not knowing who's positive and who's not, really handcuffed us early on to be able to observe and know how and when to treat those patients.
Now, say, for example, communities throughout the country, I'm going to be speaking with some other people in different parts of the country. Say that there's a town of 50,000 or 75,000 in the Intermountain West area or something like that, that maybe they haven't been hit hard yet. Maybe they're scattered out enough where the virus hasn't been big. Maybe they've got a few cases, but it's not really a pandemic for them as of yet. What advice could you give them based on what you guys have experienced? Anything they could learn from you guys?
Well, I think, again, the federal recommendations probably are the best guidelines to follow. Social distance. While it's crippling to the economy to shut things down,
Mm-hmm.
I think that sets kind of the tone and the intensity with which the community needs to understand how severe this is. And it's easy to say, oh, social distance, when all the bars and restaurants are open for dine-in and that kind of thing. It doesn't send the right message. I mean, I think that what needs to be learned is if there's hope of flattening the curve, it's by following those federal recommendations
Mhm.
and social distancing and essential businesses only, and keeping people away from each other as much as they possibly can for just a few weeks. Because I think if the virus doesn't get a foothold in the community, it's not going to be a long-term problem. The problem is when one gets it and infects five and they infect five each. And I mean, it's just an exponential rapid growth, and keeping away from each other is how to prevent that exponential growth.
So if you could go back and you say you had that, you and I have talked about having a crystal ball occasionally. If you could have had a crystal ball a year ago, what would you have done? Would you have done anything differently and prepared personally, professionally for anything that's happening now? Or was this just so unforeseen, there's no way to predict it, how you could change?
Yeah, other than having a little more personal protective equipment available, you know, we were in a good position. I don't know that there's any way to professionally predict this, but you know, Scott Steiner, our CEO, was seen on CNN and ABC saying that we went through 6 months of personal protective equipment in 6 days here. So
Wow.
even though you feel like you have enough, you just burn through that when you have a huge onslaught of positive patients.
Tell me just quickly, what's the hardest part of being a doctor right now?
That's, I don't know. I don't know. I enjoy what I do. There is satisfaction in taking care of patients. You don't get the immediate satisfaction, immediate return. But you know, I can't imagine doing anything differently than what I'm doing now. And it's challenging. It's emotionally challenging. Actually, our busy time in the operating room is going to start in a month or 2 months or 3 months, when all these cases that have not been done get done all of a sudden. It's emotionally challenging now. It'll be physically challenging in 3 months.
Gotcha. Um, you know, as you know, it's been nearly impossible to interview and recruit physicians at this point. Um, in your opinion, how do you think this will affect the needs you all thought were on your list prior to this all happening? Do you think that those people will still be the ones that you need to go after? Or do you think this whole thing is going to drive different specialties feeling you need them because of these types of situations? Or what are your thoughts?
I don't know that we're going to see a huge difference in what our plan is. Again, this is a unique situation, and it's hard to plan and staff for situations that occur. I mean, the last epidemic or pandemic of this magnitude they talk about was back in 1918. Well, that's 102 years ago. I can't imagine staffing for 102 years for the next event like this that happens. I think you have to take care of your daily business. And then when an event like this comes up, everybody's got to chip in, do what they need to do, and take care of people the best that you can.
Okay, just got a couple more and then we'll let you get back to, hopefully you can enjoy a little dinner, even if it's by yourself. But um, as physicians, I know that you guys are 100% invested in always taking care of your patients in the community. As a leader of the business, as a leader of the group for so many years, and I know you're still, you're the head of anesthesia and you're still considered a big leader in the community. How do you get yourself to the other side of this as unscathed as possible from a business standpoint?
Well, it's a challenge because you know our revenue from a business standpoint is way down. Our physician revenue, professional fees are way down. The health systems fees or reimbursement revenue stream is way down. We don't know what the reimbursement is going to be like for these COVID patients. And honestly, the health system has taken an attitude of, we'll work that out later. We're going to take care of people first. And I agree with that completely. They've kept staff on the payroll. They've not laid people off. They've not furloughed people. We're hoping that, you know, in the next few weeks or month and a half, we'll be through this and we'll need all those people back again. But they've tried to find things for the staff to do, even though it may not be in their job description. So for over 3 weeks now, we've gotten our temperature taken every day when we come to the hospital. And if your temperature is above 99.4, you don't get to come in. So that's a new position. So people in the outpatient offices may be the ones staffing the 4 main entrances to the hospital checking temperatures. We have people that help clean. We have that's not their responsibility, because there's a much higher emphasis on cleaning the keyboards of the computer terminals and
Mhm.
the door handles. I mean, there's not enough environmental service staff to do all of that right now. So there are people who have other jobs whose other jobs have been affected by this, that have taken up the cleaning cloths and started doing those things. And so the system has done a great job to try and keep people active and productive. And if we see an end to this before too long, I think that we'll be okay. I mean, it'll probably be the current president of the physician group says he's looking at this as a 2-year process, not a 1 year at a time process, because we're going to be hammered this fiscal year by all this. But I think over the 2 years, this year and next year, I think by and large will be okay from a revenue standpoint and from a business standpoint. So if you have a longer view, if you're not managing quarter to quarter, I think it's a lot easier to come through this on the other side.
Yeah, well, none of this surprises me. Your hospital and your medical group are class act, and the people there are fortunate to have you. The last thing I'll ask you is, I do hear from people, a lot of people who aren't on the front lines, or they're skilled to be able to go help patients and such, that are saying, "What can I do to help?" So I know we ask that question. My friends ask those questions. What would you say to those people who are saying, "What can we do to help the people on the front line?"
The first thing I would tell them is don't become a patient. So social distance, do what you're supposed to do, don't become a patient. The other thing that's helpful to us, I have a friend who sent me a video of trumpet players who created this music video to honor the healthcare workers and the frontline people, and just a simple thank you, and a phone call to check on your friends who are in healthcare to say, hey, how you doing? How you holding up? Good to talk to you. Just something, to a familiar voice, just an interest on the part of them. And if there's something that you can help with personally to your friend will say, well, gee, I could really use this, or I could use that, or thanks for calling. But just, number one, don't become a patient, and number two, just be a good friend, and that's the best way to help out, I think.
Well, listen, I thank you for being such a good friend. I've always enjoyed spending time with you, and we love coming to Albany every time we get a chance. And we'll be there again soon, I have no doubt. And thank you for everything you're doing. I really appreciate it.
Well, thank you. I appreciate it too, and I value you as a friend as well.
Thanks, Rich.
Talk to you later, Tony.
All right. Bye bye.